In this video, we're going to look at the pharmacology of lidocaine, specifically the use of lidocaine in treating patients in refractory VTAC and VF in cardiac arrest. In order to appreciate how lidocaine performs its mechanism of action, we have to look at first where it's going to actually function. And in the cardiovascular system, we're watching lidocaine perform its action on the non-nodal tissues. So what this means is these are going to be the tissues that live outside of the normal pacemaker. So this isn't the SAV node or the SA node or the AV node. These are the non-nodal tissues. So lidocaine works on the non-nodal tissues. And these tissues are going to include the cardiac myocytes. So this is going to be cardiac myocytes as well as the Purkinje fibers. And the reason for this being relevant is that these uh, tissues are going to live in the ventricles, and that's what's going to give lidocaine a primarily ventricular function. So again, because it works in the cardiac myocytes and the Purkinje fibers, lidocaine is going to perform its function in the ventricle, which is going to be relevant when we're looking at treating someone who has something like VTAC or VF, especially when it's refractory in nature. So to understand how lidocaine works, we first have to look at the normal action potential for the non-nodal tissues. So what we're looking at here is the non-nodal action potential. And this will give us some perspective about how lidocaine is actually going to perform its function in reducing the ability of VTAC or VF to recur or be refractory. So what happens when the nodal tissues fire, we start to see an action potential being pushed through the conduction system. We have an influx of sodium into our cells, and as they meet other cells, they'll hit a threshold potential. So what you can see here is as we get into this kind of sharp upward curve, right here is where we've hit a threshold potential. And what happens when you hit that threshold potential is you open sodium channels. So this is what we call phase zero of the non-nodal tissue action potentials. We have phase zero. And what's happening here is we get sodium channel opening, and you start to see an influx of sodium. So the cells are going to see an influx of sodium as a result, or sodium is going to enter the cell. And it's this influx of sodium which is promoting this depolarization. So as sodium enters the cell, you see the myocyte or the non-nodal tissue becoming more positive, which is going to allow for depolarization. This is where you get contraction of the ventricles, and that tissue is actually going to allow for output. So phase zero, it's stimulated by the nodal tissue. We're seeing sodium channels opening, and we get an influx of sodium until we hit this peak. What happens at the end of this peak is what we call phase one. So now we'll transition into phase one of the non-nodal action potential. And what's happening here is you see closure of sodium channels. So sodium channels are going to close. And what we're actually going to see is an opening of voltage-gated potassium channels. And what you start to see as a result is potassium efflux, or potassium starts to leave the cell. And it's that potassium efflux that is responsible for this downward slope. So if you think about what we said, the influx of potassium was the influx of sodium was making the cells more positive. As a result, the efflux of potassium is making them more negative, so we start to get this downslope. Now, we don't see the downslope last very long because when we hit phase two of the action potential, this is going to be the plateau phase. And what's happening in the plateau phase is you have opening of calcium channels, which is going to allow for an influx of calcium. So we open potassium channels, we have an influx of calcium. And if you think about what's happening now, I have calcium moving into the cell, I have potassium moving out of the cell. So what I get is a net equal charge, or I'm not having a positive or negative charge. So we have that neutral charge, which is allowing for that plateau. Now, following the plateau, we end up in what's called phase three of the action potential. So this is phase three, which is going to be characterized by a fairly profound repolarization or hyperpolarization of the cell. And what's happening here is that those calcium channels close. So you see the closure of the calcium channels. What's happening is we just have those potassium channels open. So if it's just those potassium channels open, then all we're seeing here is potassium efflux, which again, if potassium is leaving that cell, we know that creates a negative deflection, and that's what's happening here, is we're having potassium efflux from this cell, which is leading to that repolarization. Now, if you think about what's happened is we have a whole bunch of potassium outside of the cell and a whole bunch of sodium inside the cell. So phase four of our action potential, or this final phase of our action potential, the whole role of this phase is we have the sodium-potassium pump putting our electrolytes back to the right parts of the membrane. So sodium-potassium pump move our sodium-potassium back to their normal position. So we start to see movement of these ions back to their normal positions. That is what's going to allow for us to have another action potential following this. So what we'll do is we'll recap in a list form here. So again, what's happening in phase 0 is we have the opening of voltage-gated sodium channels, and we have sodium influx, which is making our membrane potential more positive, and we see this upward slope. Once we get to phase 1, our sodium channels close and our potassium channels open, and we'll have efflux of potassium, which is allowing for this downward deflection. In stage 2, we open calcium channels. This is part of what's allowing for strong contraction of those muscles, and this causes the plateau phase of the non-nodal action potential. In phase 3, we have closure of those calcium channels and then opening, or the potassium channels remain open, so we're going to have efflux of potassium. And then as we get back to our baseline, we know that our sodium-potassium pump is going to have to move our ions back to their normal positions because everything's out of place right now. And that's what's happening in our phase 4 of the action potential. So when we look at lidocaine, we know it works in the non-nodal tissues. So it's working in the Purkinje fibers and the myocytes, which have this type of action potential. So when we look at the mechanism of action of lidocaine, or what does it actually do? The job of lidocaine is to block our fast sodium channels. And these are going to be the channels that live in the non-nodal tissues. So we're looking at these sodium channels that live in the non-nodal tissues that are responsible for phase 0 of our action potential. So when we're giving someone lidocaine, what we're doing is we're blocking fast sodium channels in the non-nodal tissue. So if you think about what happens, and we'll draw this in red here, when we give lidocaine, we block those sodium channels. Sodium cannot as easily enter the cell, or we can't have influx of potassium occurring at the same rate as we would if those sodium channels were open. So what happens when you give lidocaine is you impact phase 0. So this is where lidocaine will perform its function, is on phase 0. What it's going to do is it's going to block the opening of voltage-gated sodium channels. So what we see in this instance is if those sodium channels are blocked, we have a slower influx of potassium. Those sodium channels are blocked, we have a slower influx of sodium, which will prolong phase 0 of our action potential and starts to pull this action potential out, or it makes it much longer. So if you think about the impact of this, we're going to see a decrease in the rate and speed of phase 0 of our action potentials. We're prolonging phase 0 of the action potential. And as a result of that prolongation, the entire action potential gets spread out. And what that means is that I'm going to have longer refractory periods, or basically the time in which we cannot have another action potential is going to go up. So we get a longer refractory period, or the time between action potentials goes up. So we've looked at the mechanism of action of lidocaine. Now we can actually take a look at how does this mechanism lead to a reduced potential for something like refractory or recurrent VTAC or VF. And this is going to relate a lot to this prolongation of phase 0. So if we remember, we talked about the fact that lidocaine is going to block fast sodium channels in the non-nodal tissue, so the Purkinje fibers and the myocytes, which is going to lead to prolongation of phase 0. And you can see that in the red lined graph here, is that prolongation of phase 0 is going to lead basically to prolongation of the action potential, which has a couple of really important effects that will reduce the ability of the heart to go back into VTAC or VF. One is that we're going to see an increase or prolongation of the refractory period. So we get an increased refractory period, and what that means is there's going to be decreased ability, or basically an increase in time before the cell can be excited again. So with an increase in refractory period, what that means is that the period in time in which the cell can't be re-excited is going to be longer. So the tissue is less irritable because it cannot be excited for a longer period of time. So again, important to remember that increase in refractory period is going to lead to a decrease in excitability. The other piece to be mindful here of is that we're going to see a reduction in the velocity of our action potentials. So the other thing that we see is a decrease in velocity of the action potential. And what that means is that we're not going to be able to stimulate the surrounding tissues as aggressively, or essentially the rate at which the surrounding tissues depolarizes is going to be reduced. So we see a slower action potential, or the velocity of that action potential is going to be reduced. And these two things are going to play an important role when we look at something like VTAC or VF. So let's take a look at how these two things, an increase in refractory period and a reduction in action potential velocity, can impact VTAC. When someone's experiencing VTAC and cardiac arrest, what is traditionally happening is they have myocardial damage or damage to the non-nodal tissue in the ventricle, which is preventing the normal conduction pathway. And in VTAC, what's happening is actually a couple of different conduction pathways are forming, or an accessory pathway forms. So what you can envision here is this is the ischemia. So we've got some sort of ischemia that is formed in the conduction system, or the conduction tissue of the ventricle, which is now preventing the laminar or the unilateral flow of electricity from wherever conduction is starting to wherever conduction is going. So if this is point A to point B, normally there would be a single path for the impulse to get from point A to point B. Now, when we create ischemia, I open the ability to have two directions for the impulse to travel in, and that's what's happening in an accessory pathway. Is the ischemia is essentially creating a roundabout where there typically would be a straight highway. So what happens is we have an impulse that's coming from the upper portion of the heart that's trying to travel through the conduction system. Now we won't get through the entire physiology of reentry, but in order for a reentry tachycardia to occur, what happens is usually we would see an impulse like this split into two directions. So if an impulse coming down that meets an accessory pathway, what we'll commonly see is that impulse will split in two directions, travel down both sides at a similar pace, stimulate the ventricles, and we don't have any issues. Now, what happens when someone has ischemia to their heart tissue is the heart can become more irritable or can have much more damage, which will promote asymmetrical travel of this conduction or this electricity through the conduction system. So instead of branching off and forking down both sides of the accessory pathway, what often happens is we see the impulse come down, it will then travel down a single side of the accessory pathway that's present, will head down towards the ventricles, but this opens the ability of this impulse to now cycle back up the accessory pathway that's present and come back to the beginning or the initiation of where our electrical conduction was coming from. And the problem that exists is we know that we have a refractory period that follows this. So picture we have this refractory period that is traveling along this impulse. Well, what can happen is if that impulse makes it back to the top of the conduction system when this tissue is out of refractory, what can happen is you see that impulse be able to cycle through again, or essentially it will make its way back up. So we said the impulse traveled down like this, went around, stimulated the ventricles, came back up, and if it can meet this tissue here, so this tissue right here, when it is out of its refractory period, this tissue can now create a feedback loop or a reentry loop that will now take over as the pacemaker. And that's what's happening in VTAC is either a premature beat is occurring or there's a blockage somewhere in this accessory pathway that is allowing a reentry tachycardia to occur. So this little reentry pathway that's formed due to the accessory pathway that's present will initiate, and this is a very small microscopic piece of tissue. So the ability, or when we look at the impulse traveling around this circle, it's going to travel really fast. Again, picture this as being kind of a microscopic area here. Well, normally we watch impulse travel from the top all the way down across both our bundle branches. Well, in VTAC now, instead of having this big conduction system or nodal pathway that is controlling the speed of our heartbeat, we have this tiny little microscopic roundabout of electricity that is trying to generate impulses at an extremely fast rate. So in order to initiate this, one of the things that's really important is that this tissue needs to be out of its refractory period. We call that critical timing. So in order to have reentry, you must have critical timing. So if you think about the benefit then, so what is the benefit of giving lidocaine to these patients is if I can increase the refractory period, I'm going to increase the amount of time that this tissue is in refractory, making it much more challenging for this impulse coming back up the accessory pathway to stimulate that tissue. So when I prolong the refractory, basically you're trying to reduce the ability to have critical timing. So when you see an increase in refractory, what that leads to is a decreased ability to meet critical timing. And as a result, what that's going to lead to is a decrease in the ability of a reentry loop to form. And that will limit VTAC. So if we can't have reentry, then we can't have VTAC. So ultimately, what that's going to do is reduce the amount of VTAC that a patient is going to have. And that's the benefit of giving lidocaine to someone who's in refractory ventricular tachycardia, is you're making it much more challenging for that reentry circuit or that accessory pathway to create the reentry loop. So just because the accessory pathway is present doesn't mean that reentry is going to happen. You must have critical timing. So when you give lidocaine, you prolong phase zero and prolong the refractory period. What you're doing is making it much harder for this reentry circuit to occur, as a result, reducing the amount of VTAC that you'll have. Now, there are a number of theories that also suggest that something like VF, or ventricular fibrillation, is the result of a reentry loop, that it's simply sending out these wave-like projections to different areas of the ventricle. So if that's the case, if that's what's resulting in ventricular fibrillation, then reducing the ability of a reentry loop to occur will also reduce those types of VF. The other thought behind ventricular fibrillation is that there are multiple ectopic foci that are trying to send signals out to the ventricles. So because the heart is so irritable, we have a lot of acids, electrolytes, and damage occurring, you have multiple ectopic foci that are causing the ventricular fibrillation. If that is the case, giving lidocaine can also be effective because we'll shut down some of those multiple ectopic foci by increasing their refractory period. So reduce ectopy by increasing the refractory period. The other benefit is that if we're going to decrease the velocity of action potentials, these ectopic foci are firing slower and have less ability to impact the surrounding tissue. So when we have multiple ectopic foci, there is a benefit to also reducing the velocity in which they're firing at, which will also, again, reduce the irritability of the surrounding tissue. So again, there's a couple benefits here. The mechanism of action of lidocaine is to prolong phase zero and essentially reduce the velocity of an action potential, so it fires slower. When we look at how does that actually relate to ventricular tachycardia, well, that's going to increase the refractory period in our accessory pathway, making it much more challenging for that reentry loop to occur. If I can't meet critical timing, or if every time this impulse makes it back to this point, if that tissue is in refractory, then you won't have a reentry circuit form, and you're not as likely to get VTAC, and in some cases you'll be less likely to get VF if this is the etiology of that ventricular fibrillation. The other benefit to lidocaine in someone who's experiencing refractory or recurrent ventricular fibrillation is that they have multiple ectopic foci, which is essentially the result of irritability. If I can increase the refractory period and decrease the velocity in which those ectopic beats are going to fire, then they're going to have less ability to irritate the surrounding tissue and less ability to create that rhythm. So I'm essentially opening up the ability of the upper parts of the heart to take over. And that's the last key point to remember, is that when we're talking about lidocaine, we're talking about a drug that is working on the non-nodal tissues. So the whole premise behind giving this drug is, can I shut down a reentry pathway or slow down ectopic foci that are occurring in the non-nodal tissue to provide the nodal tissues time to take over as the primary pacemaker and prevent these either ectopic foci or reentry tachycardia from driving the heart rate and the function of the ventricles. So I hope that helps with an understanding of how lidocaine works.